looking forward to the first presentation, which I mentioned already, will be given by Professor Maria Buti. Just to mention briefly, she's a well-known hepatology professor of medicine, work at the University Hospital Vall d'Hebron in Barcelona. Actually, she has been working in viral hepatitis field for many years and focusing particularly in the diagnosis and therapy for hepatitis B, C, and D. She also is the chair of the Secretary of Public Health at ISL and associate editor of Journal of Hepatology. I think she has made so many outstanding publication contribution to the field that she doesn't need really further introduction, and we're just looking forward to hear her presentation. Please, Maria, go ahead.
Thank you, Maura, for the introduction. Hi, everybody. I am going to focus on the burden of hepatitis delta and the epidemiology. Next, here you have my disclosures. And let's start with the burden of hepatitis delta, the global epidemiology. And I would like to mention next 3 studies published in the last 4 years that estimates the prevalence of hepatitis delta among people living with hepatitis B. And the prevalence is very variable between 4.5 to 15%. And that means that approximately between 48 and 72 million of people could be infected with hepatitis delta. And you can see in the map that there are countries with the higher prevalence in red and others in light red or even orange. The prevalence is lower, and it clearly depends on the introduction of hepatitis B vaccination. Countries with high coverage of hepatitis B vaccination has the lowest prevalence. And the highest prevalence are particularly in Africa and in Central Asia. And next slide. Here we can see the results of a study performed by Mario Risetto, showing that in red, the countries with the highest prevalence of hepatitis B also have the highest prevalence of hepatitis delta. But also it's important to realize that there is no data, no information in many countries. And probably this is related with the lack of testing. Next. Another important point is that the prevalence of hepatitis delta is completely different depending on the risk of adhesion of this infection. Is much higher in people who inject drugs, but it's also completely different in settings in the blood banks. The prevalence of hepatitis delta is lower than in those pathology centers, particularly the prevalence is higher in patients with liver cirrhosis and hepatocellular carcinoma. Next. So there is specific populations that have the higher likelihood of having hepatitis delta, that are patients with hepatitis C and HIV, that it's between 6 and 10 times higher than the general population. As I mentioned previously, in patients with cirrhosis and hepatocellular carcinoma are more likely to have been exposed to hepatitis delta with prevalence between 7 and 5 times higher than the general population. Next. The majority of studies in general, in the prevalence of hepatitis delta have been done using anti-delta antibodies, but not all patients with anti-delta antibodies have true hepatitis delta, only those with detectable viremia. undetectable viremia is tested in less studies than anti-delta, and the prevalence of viremia ranges between 40 and 73%, meaning that to better understand the burden of hepatitis delta, it's very important also to test for delta viremia. Next. These are data from Europe, from different European countries. You can see German, it's estimated 32,000 people infected. In France, 31,000. In Italy, 49,000. And in Spain, 69,000. But I think these data clearly overestimate the prevalence of hepatitis delta, because if you look at different studies, you can see, and these are data from Spain, you can see an important decline in the prevalence of hepatitis delta, particularly for acute hepatitis delta. I can tell you this is all data, but we are continuous register all the cases of hepatitis delta in my center, and we have seen an important decline in the number of cases of hepatitis delta. We haven't seen acute hepatitis delta in the last 8 years. And now the majority of patients have chronic hepatitis delta. And usually the patients now diagnosed with hepatitis delta are migrants or local people of advanced age. And this is the decline in the prevalence of hepatitis delta. It's clearly related with hepatitis B vaccination and improvement in the public health system. Next. Very recently, this study estimates, it's a literature review that estimates the prevalence of, next please, that estimates the prevalence of hepatitis delta next in 21 countries and territories. And you can see here new data adjusted for geographical distribution, disease stage, and special populations. And the prevalence of hepatitis delta is much lower. It's 1.3 of anti-delta antibodies, and probably 66% of them, these are estimations, have active delta infection. Next. Next, please. Next slide. And next. So, in summary, the true global prevalence of hepatitis delta is unknown due to insufficient data, and there is insufficient data regarding testing because anti-delta antibodies are not available in all countries. Even in some countries like US, anti-delta antibodies are not registered. Also, the prevalence of active infection in the majority of countries, it's not very well known due to the lack of assays to determine the viremia. And finally, the prevalence of hepatitis delta changes in different settings and in different countries, showing that clearly we need better data to evaluate the prevalence of hepatitis delta. Next. A critical point next, and I think Fabian Sulim will speak later, it's a screening. And the guidelines recommend a screening for hepatitis delta. In the majority of the guidelines, the American guidelines, the APASL guidelines, only for patients with risk factors or chronic liver disease. These guidelines are the only one that clearly recommend all infected patients with hepatitis B have to be tested for hepatitis delta. And next, and I can tell you that now ICE has released during the ICE Congress specific guidelines for hepatitis delta. And the recommendation is screening for anti-delta antibodies should be done once in all HBs antigen positive, and those with risk factors need to be retested for anti-delta antibodies, or those that have specific clinical situations that indicates the need for testing for delta antibodies. Next. I think this is an important recommendation, but the recommendations of guidelines, the application of these recommendations is usually very low. I can show data from my country showing that in a retrospective study, testing for anti-delta antibodies overall is very low. Only 10% of those HBs antigen positive has been tested for anti-delta antibodies overall, higher in a clinical setting, lower in the general practice. We apply the reflex testing for delta antibodies, and using reflex testing, we can increase the number of cases diagnosed with hepatitis delta. There is a 5-fold increase in the number of cases diagnosed. And for me, what is really important is that more than half of these individuals didn't have risk factors for hepatitis delta. Next. An important question is if it's cost effective to do reflex testing. And these are new data presented at ICE Congress showing that reflex testing is able to reduce the rate of liver cirrhosis, liver decompensation, hepatocellular carcinoma, and liver death. We apply reflex testing in it's a Markov model looking at the application of reflex testing in all my country, and we can see an important reduction in liver-related complications between 30–37%, and also we show that it's cost saving to do reflex testing once time for every people living with hepatitis B. Next. Let's move now to the clinical consequences of hepatitis delta infections. Next, please. Next slide. Sorry, but it's a delay. So this is the algorithm for the evaluation of hepatitis delta. So all patients need to be tested for viremia, and those with viremia, it's important to assess the liver damage. So now looking at the clinical consequences of hepatitis delta. Next. Next. Next, please. Next. Next. One more. I don't know what happened, but we are going back.
There is the problem with the connection, perhaps, because we are looking at increased risk of long-term consequences of viral hepatitis.
Okay, so probably it's a problem of connection. Sorry.
Please keep in mind the time.
Yeah. Okay, next slide.
For us, one back.
Okay, so patients with chronic hepatitis delta have a higher risk of presented complications. The risk is it's higher than those non-infected with hepatitis B. The risk of cirrhosis is 2 or 3 times higher for hepatocellular carcinoma. For hepatic decompensation, even for liver transplant, and mortality. And next. Ability of developing clinical events, it's clearly associated with the persistence of viremia. This is a study that patients with hepatitis delta were followed for more than 19 years, and we can see the factors associated with a worse outcome are persistent delta viremia, and also men's cirrhosis at the time of diagnosis, and hepatitis delta is still an important cause of liver transplantation. And in a recent study presented at the last ISL meeting by Patricia Burra, that is the Italian experience in the liver transplant setting, approximately half of the patients transplanted for hepatitis B had also anti-delta antibodies. So even in countries with hepatitis B vaccination, hepatitis delta continues to be an important cause of liver transplant. So in summary, we still have a lot of gaps in the prevalence of hepatitis delta. Hepatitis delta screening by reflex testing can help to improve the data on the prevalence and the burden of the disease. It's important to remind that hepatitis delta is the most severe form of viral hepatitis, and the presence and persistence of viremia is associated with the worst outcomes. Thank you very much,